Well, hello. We didn't see you there.
How are you?
Hey, everybody. Dr. Spencer.
Hey, I'm Dr. David.
We are really excited to tell you that D-dimers are coming to clinic.
Yep, absolutely.
People have been asking for it for a long time.
Oh, yeah.
Me included. And finally, it's coming to clinic. I know you guys know this, so we're going to do the briefest of overviews on D-dimer, as well as some information that David's sending out.
Yep.
Obviously, D-dimer is an inflammatory marker, as well as an indication of possible clot. That is typically what we use it for. In COVID, in the hospital, they'd trend D-dimer to make sure it was going down as an inflammatory marker. Most of the time in the urgent care setting, what we're going to use it for is I come in and my calf is painful, or my arm is painful and swollen, or I'm having some chest pain or shortness of breath, but I have a low suspicion for something. I don't really feel like that strongly this needs an ultrasound. So I can get a quick blood test, and if it's below a certain amount and the rest of the criteria look good, using PERC, Wills, all that kind of stuff, I can feel comfortable saying you probably don't have a clot.
Absolutely. And we have the educational piece that we'll have coming out with this is going to be a little more robust. It's going to be a lot of reading, but it has these same bullet points that we're going over. And like you talked about, there's different ways to use the D-dimer, but the way that we envision it being used in our clinics is to help us do this full chest pain workup, or this full, pulmonary embolism workup if you think they have a DVT, which does come with some things that we need to remember and we need to start documenting. Like you talked about, the scoring systems, the PERC, the Wells, things like that. And we do need to understand that this is an age-adjusted laboratory value as well. So those are all things we need to keep in mind. And like I said, we have something written in a written form with some bullet points that are going to help you kind of navigate through that, but do remember and familiarize yourself with some of those things. I think that'll be important.
And once you start getting into it's elevated, but for their age, it's about right, but might be a clot, call your supervising physician if you felt like you're in a gray area at all. I like it as negative good.
Yep.
Once I get in a gray area, I'm pretty low threshold to get a definitive test.
Absolutely. Absolutely.
Especially in elderly patients, pregnant patient, where the D-dimer is just going to be weird anyway.
Yep.
In emergency medicine, they call it rolling the D-dimer dice, because I know there's not a clot in their leg, but it's also an inflammatory marker. It can be elevated for a bunch of weird reasons. So I roll the dice, they're negative, you don't have a clot. I roll the dice, it's positive. Dude, you don't have a clot, but now we got to get an ultrasound in his leg because it came back. So, but anyway, I'm excited to have it. Tired of sending people to different imaging centers and ERs for a leg that I'm sure doesn't have a clot, but I can't get a D-dimer.
Yeah.
So I think this is going to be a good addition to our clinics, and I think it's going to make our patients really happy and make your lives much easier.
Absolutely. And just for the very briefest of moments, remember this will be in your provider protocols as well. Don't forget to look at those. Don't forget to implement them, and make sure your back staff understand them too.
Yeah. All right. Like he said, make sure all your scores are going in, heart score, D-dimer, or the PERC, the Wills, all that kind of stuff. If you have any questions, reach out to myself, reach out to Dr. Coltrider, any one of the supervising physicians, regional medical directors, or Dr. Meredith. I think everyone has his cell phone. Appreciate all the hard work you guys do. Thank you so much.
Thank you.